Back in March, there were strict criteria to get tested for COVID-19 in Ontario. Even if you had symptoms, it didn't necessarily mean you got a test. That expanded somewhat over time, but faced mounting criticism as the case counts continued to rise here. Last week, the government unveiled a new, much more ambitious testing strategy. Is it up to the task? Let's ask. Colin Furness, he is an infection control epidemiologist and an assistant professor at the Faculty of Information at the U of T, cross-appointed to the School of Public Health, and he joins us now from the provincial capital. And I guess I just want to start by asking you, how are you managing through this pandemic?
Well, I have two kids at home, and that's a big challenge. I think I'm really hoping we can get schools open. Apart from that, we're doing okay.
You think the schools will open?
I think that'll depend on our testing strategy. We could do it safely, and my fear is that we won't start in time planning for that.
Well, let's talk about that testing strategy, and maybe that'll give us a hint as to where things are going. Under the new plan that was just announced by the province, who can get tested now and where?
Well, under this new plan, you can show up at an assessment center, and there's many of them throughout the province, at hospitals and elsewhere. And all you need to do is show up and you can get a test. It's a no questions asked arrangement now, which marks a great improvement or expansion on the way it had been done.
No referral from your doctor needed?
Correct.
Free of charge?
Yes.
What were you most happy to see about this updated strategy?
Well, I think the standard orthodox approach that we had been using out of the textbooks is to treat testing as a scarce resource, meaning you only use it when you need to, when you're fairly sure you'll get a positive test, and when the result will have some kind of consequence for treatment. So people had to be really, really ill in order to qualify for a test. But this is an asymptomatic pandemic. People can spread it through feeling mildly ill or feeling actually completely fine. So there was a big mismatch. And I'm delighted now, although it is 2.5 months later than it should have been, delighted that we are actually expanding that testing now.
Well, you've anticipated my next question because I was going to ask you about the timing. You say it's 2.5 months too late. How come?
Well, we've known since February that this is an asymptomatic pandemic, that the thing to be really worried about are not people who look really sick, but people who don't, but who still may be spreading it. And we knew that as it was raging through Europe. We had plenty of case reports to tell us pretty convincingly that the thing to worry about were people who felt fine, but who were nonetheless very contagious.
Now, it was the middle of March, of course, that we began to shut things down. And here we are in the first week of June before we're finally getting the testing regimen that you think that we have needed all this time. Why do you think it's taken so long to roll this out?
I think that there has not been the expertise needed at the command table where these decisions were made. I don't know that because I haven't been present, but the decisions and the way they've been made don't square with a basic expert approach to managing the sort of thing. And I can think of a number of decisions that just leave me scratching my head wondering, how could an epidemiologist have said this is okay? They really couldn't have.
Okay, fill in the blanks. Like what?
Well, for example, changing the testing strategy at the exact same moment that you are opening up the province means that you can expect a rise in cases, but you're not going to be able to tell whether those cases are attributed to the opening or to the expanded testing. So it's almost like you're purposefully making sure that you won't be able to analyze the data. I'm sure that wasn't the case, but that's the outcome.
The Premier of Ontario, the Minister of Health, the Minister of Long-Term Care, all of the elected people at that command table all say they are taking the advice of Dr. David Williams, the Chief Medical Officer of Health for the province of Ontario, and they are doing what he is saying to do. Do you have confidence in David Williams?
I don't know exactly what conversations go on. I can think of quite clearly Dr. Williams saying he wanted to see no more than 200 cases per day before the opening of the province, and he was overruled on that. So that's pretty much the only data point I have that suggests to me that no, actually he wasn't holding sway. On the other hand, my confidence in David Williams is not what it ought to be. The testing strategy that we've desperately needed, risk-based testing, sometimes called sentinel testing, the idea that you go where the risk is, not where the symptoms are, we needed that in March. And he and his Associate Chief Medical Officer of Health wouldn't go there. In fact, his Assistant Chief Medical Officer of Health, Dr. Yaffe, said specifically, we don't want to do things like test grocery store workers because they could test negative one day and positive the next day. I'm not sure what point she was trying to make, but those words have the effect of saying we don't want to find cases. And that is exactly the opposite of what we're supposed to be doing when managing a pandemic.
Well, let me play devil's advocate here. She's not wrong in what she says. It's quite possible you could show up, get a test, the test comes back negative, but that's because the disease is still brewing and you're not showing it yet, right?
Sure, but we should go where the risk is because, again, those, let's take grocery store clerks, for example. They are frontline workers who have been ignored and in great jeopardy for 2.5 months. So, yeah, they might test negative one day, test them again. They might test positive. And if they do, let's take care of them.
Gotcha. What do you think is still missing then from the new testing regimen that the province has just outlined?
Well, most of the things that I had asked for are in there, and that makes me really quite happy. I think the big gap, well, there's two really. The first big gap is we're still saying come to the assessment center to get tested. Now that'll work for lots of people. It's not going to work for everyone. And what I mean by that is we know that COVID is particularly rampant in marginalized communities. We know it geographically, we know it occupationally. It's pretty clear. So members of those communities who may have had very few interactions with the health system, they may not have a family doctor, they may not feel that the system is for them. That may not be where they're comfortable going. And lining up and getting tested is not fun. So I think what we need to do is not just say the doors are open, come on down, but to recognize that we need to go into those communities with mobile testing. We need to connect with community leaders. We need boots on the ground right there. And that's something that I don't see. There's mention made of mobile testing, but it's not specific enough. And I'm very concerned about that.
Well, you say not specific enough. They did announce that they were bringing a mobile testing unit into a neighborhood in Scarborough. They gave the address. They told people it'll be open from 9 to 5. Go down there, get your test for free. I mean, that's going into the community, isn't it?
That's great. That's great. And we need more of that. That is what we need more of. And it should have been done already. Given that we're starting to do it now, let's do it all the way across the board because we know where those neighborhoods are. That's one. How about we do all of them?
All of them, as in how many testing sites would that then require? How many mobile testing sites?
I would think you would want more than a dozen. I think you might want a number in the dozens. That's actually a pretty hard calculation to do, and I don't have the population numbers at hand. But 1 or 2 mobile testing units is not enough. You need to be there not once. You need to be there on a continuing basis. You need to build trust. You need to not just do the one-off. It needs to be a sustained approach.
And in how many different municipalities around the province do you think we need these things?
Well, we know very clearly that we have problems in the the northwest and the northeast of Toronto. We have serious problems in Peel region. Peel region is where there's a lot of immigration. This is also where we see a lot of tuberculosis. This is not a public health surprise, but this is where we have poverty. This is where we have risky employment. This is where we have essential workers who don't have the luxury of working from home, lower education, lower nutrition. There's a lot of risk factors there. And so Peel, a little bit Durham, certainly northwest and northeast of Toronto, those would be the major areas that I would identify.
We had a bit of an outbreak in southwestern Ontario the other day among migrant workers. There's been a bit of an outbreak in Ottawa as well. Should we have mobile testing units in those 2 locations as well?
For migrant workers, absolutely. Ottawa is a little bit less clear to me because it is typically made up of, it's the wealthiest city per capita in the country. So I don't identify Ottawa as having as significant an issue with marginalized communities, but it probably does. And I think the local public health unit should be empowered. They know their terrain. They should be empowered, not from the Premier's office, but from local public health units to identify those, and they should be resourced.
Okay, let me ask you about testing per capita in the country, because I hear such disparate reports on how well or badly Ontario is doing. Can you help us out on that?
It was doing really badly if you look at it per capita. Now, Ontario is the most populous province, so that means in order to compete per capita, you need to be doing a lot of tests. As of yesterday, Ontario was in 3rd place, but growing. It was just a little bit behind Quebec and way behind Alberta. Alberta is out front on a per capita basis, but of course we're 3.5 times the size. So it's easy to say, well, we're not doing well on that basis. On the other hand, of course, this is not a surprise that we have a big population. So I think it does reflect poor planning.
Now, maybe you could help us with this as well. I know we are apparently capable. We have the capacity to do more than 20,000 tests a day, but it sure took a long time to get up to 20,000 tests a day, and we're not even every day hitting 20,000 tests. Do you know why that would be?
That is a conflict between capacity on one hand and testing strategy on the other. I think it underscores why having assessment centers with criteria and even loosening those criteria isn't enough. But the problem isn't that we're not hitting the 20,000. The real problem is that 20,000 isn't even remotely the capacity that we're going to need. In order to execute this plan that's still only a few days old, ink still wet on the page, we're going to need many multiples of 20,000 tests per day. We need to think about everyone who works at a cash register for a living. We're opening up stores, we're opening up the province. Those people, those are frontline workers. They will have occupational exposure to lots of people all day long. They are very at risk, and we need to be testing them repeatedly and continuously. And we're talking about, I think, maybe well over 100,000 tests a day. I haven't counted, but the more we open the province, the greater that number grows.
Are you talking about a scenario where we start seeing, never mind mobile units in neighborhoods, we're seeing testing capacity in every or almost every workplace?
That's what we need. We absolutely need that. I'd like to see a mobile testing van showing up at shift change, at taxi garages, at grocery stores, at malls when they open. No question. We're going to need that because you either have to do lockdown, you have to do major physical distancing, or you have to do ubiquitous testing. You've got to sign up for at least one of those if you want this to be under control. Ontario hasn't done a great job at either, and that's why we're staggering along in the position that we're in.
Dr. Furness, pool testing, that's a new thing. Tell us about that.
Pool testing was recently invented as a testing technique in Germany, and it's being deployed in Africa quite successfully. The idea is that where you're expecting mostly negative tests, because you're testing a lot of the population. What you can do is pool the tests together. So let's say 5, and test them all at once. If they're negative, then you can throw them all out and you're good. If you get a positive, then you have to go and look at each sample individually. So when you're doing wide scale testing where you're expecting most to be negative, you could, in theory, almost quintuple your testing capacity just by using this technique. And what's key about it is that there's no loss of sensitivity in the test. In other words, just because you're combining them does not mean that you're likely to miss anything. And this is a brilliant innovation, something that could really push our capacity toward what we need to in order to reopen schools.
Do they know about this at the command table, and can we get it here?
I don't know what expertise makes its way to the command table, and I fear that not enough does, but it's being reported. If I heard of it, it can't be that hard to hear about. And I really, really hope that that is the sort of thing that we are able to get going here as soon as possible.
There are skyscrapers in the downtown of the capital city of this province where, on a normal day, 7,000 people will get off the subways and show up for work. Can you do testing and physical distancing adequately in settings like that?
How we're going to cope with high rises is a very interesting question. That's very concerning. We can't redesign those workspaces easily. We can't just think that we're not going to use those buildings from now on. I suspect some companies will move out. Some companies won't survive. So there may be some thinning, but the elevators are probably the biggest cause of concern. And I think there's more than one kind of testing we can do. It's possible to do a pulse oximeter testing where you put your finger in a little slot and 3 seconds later, it tells you your blood oxygen saturation. That's not going to identify every case, but that will identify at least some COVID cases. And that's as easy as pushing the call button for an elevator. So I think we can get creative doing that. But I think we're also probably going to need a pretty serious protocol around elevator capacity and probably wearing respirator masks in elevators. I know that sounds extreme, and it also depends on us having a sufficient supply of those kinds of masks for healthcare workers. But that's something that we're really going to have to be concerned about. I would not be comfortable going into a crowded elevator, not till we're way past this pandemic.
No, it doesn't sound extreme to me. I can imagine if you're going to try to do physical distancing in an elevator, that basically means 10% of the people who could take one ride are going to be able to, which essentially means it's going to take you 2 hours to get up to your office. I mean, that's just not going to work, right?
That's the problem. Yes.
That's
exactly.
the problem. Okay. We talked about schools briefly at the beginning. I want to come back to that right now. I presume you are also imagining a scenario where, it's not too tough to get teachers to get tested frequently when they show up to school, but there are schools with thousands of kids in them in this province. Can you actually test kids as they arrive for school every day as well?
I don't think we can get to the point of testing every child every day. And don't forget that it's very unpleasant to have a deep nasal swab, and that's going to be a hard sell for kids. So this is a difficult problem. But again, a pulse oximeter would be a really good screening tool. I'm not going to call it testing, but I'm going to call it screening. If we could have every child screened that way, the idea is that if you've got a lung full of virus, but you feel fine, which is typically how it presents with children, that will get typically picked up by a pulse oximeter. I don't think it'll catch every case. I don't think it would, but it will catch a lot of cases. And if you just get one, then you can go in and test an entire class. So it would be an effective screening tool. And yes, I would be testing teachers frequently, and we need to be in every school. And we need to do that planning now. The idea that we're 2.5 months behind the curveball in our testing strategy is not going to fly come September. So we have now just about 3 months to get that in place so that we can open schools. And I think that's probably the most important task we have as a province right now.
That test that they do, where they put the swab up your nose, and I've heard people who've had it say they can feel it touching their brain. That's how far up the nose it feels like it's going. How accurate is that test?
Well, so that's the specimen collection, and of course that can be done competently or not competently, or you could get lucky or sorry, unlucky in terms of not happening to catch virus on the swab when you're doing it. It has to go deep in order to have a good chance of getting the virus. Once that specimen's been collected, as long as it's handled properly and not contaminated and makes its way in good time to the testing facility, the technology that's used, which is called PCR, is the gold standard. No test is 100%, but it's kind of assumed to be because there isn't a better way to do testing. So you still can get false negatives, that is, you're sick, but the test fails to notice that if the sample has been degraded or the sample wasn't adequately taken. Those are typically ways that you end up with false negatives. We might get false, or there's another way to get a false negative, which is if the virus manages to mutate beyond what the test can identify, in the same way that viruses can mutate beyond what your immune system can identify. We haven't seen that happening so much with COVID. That's one piece of good news in all this. It's not rapidly mutating. So those are your false negatives. You can also get a false positive test where you're fine, but the test says you're sick. That's a lot more rare, and typically that would be a fumble in the lab where samples got mixed together or contaminated.
I got 20 seconds left to ask you about so-called serology tests, Serology, where they take blood and look for antibodies. What part does that play in the whole testing regimen?
That's extremely important. It's not as important in the acute phase, which is when it's rampant, but we really want to know what the immunity in the population is. And just yesterday, I read the results of a study that's in press that suggests that there is some population immunity based on exposure to the common cold coronaviruses. We don't know yet what that means. Does that mean that you won't get COVID? Does that mean that you would get a mild case? It would be amazing to know that. That's incredibly important, and I would like to get serology testing rolled out to as many people as possible as soon as possible so that we can learn what our trajectory is.
Colin Furness, it's great to have you on the agenda again. I guess you were on about 6 years ago. Long overdue that we've had you back, so thanks for doing this.
My pleasure.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.